Welcome back to January 26th through 27 board meeting. My name is Song Oh, president of the board. Before we convene, I would like to remind everyone present the board is a consumer protection agency charged with administering and enforcing pharmacy law. Where protection of the public is inconsistent with other interests sought to be promoted, the protection of the public shall be paramount. As I facilitate this meeting, I will announce when we are accepting public comment. As the agenda details, the board has significant business to complete. To ensure the board has sufficient time to complete all of its necessary work, I have advised the meeting moderator to allot 2 minutes to each individual providing comments. As stated, over the past several meetings, the board has faced time constraints resulting in deferral of discussions. To address this, again, we are reducing public comment to 2 minutes. As a reminder, as included in the agenda, the board provides contact information for individuals to provide written comments in advance of meetings, should they so choose. Thank you all for your understanding on this change. We'll begin with public comments for individuals attending in person, followed by public comments by individuals participating via WebEx. This approach is necessary to facilitate this meeting. Before we get started, I would like to ask staff moderating the meeting to provide general instructions. Moderator?
This is the moderator for members of the public on WebEx. When we reach public comment, you can click the raised hand icon in order to indicate that you would like to make a public comment. If you're an audio only participant, you can press *3 on your device to raise your hand. You'll be given 2 minutes to speak with a 10-second warning, and at the end of your time, your microphone will be muted and we'll move on to the next individual requesting public comment. I believe that is all the instructions I have.
Thank you, Sarah. I'd like to also remind individuals participating in the meeting via WebEx that consistent with the board's policy and with implementation of the board's new learning management system, pharmacists and pharmacy technicians attending the meeting via WebEx today may be awarded up to 6 hours of CE. Please review the information on the agenda and follow the instructions provided to ensure you're eligible. You will be required to register through the board's learning management system, PharmEd. I would like to take a roll call to establish a quorum. I know Jesse is not joining. Trevor's not joining. Renee Barker.
Good morning, licensee member present.
And would you mind announcing?
Thank you. Yes.
Thanks, Renee.
I am the only person in this office. No one
Thank you.
under 18. Thank you. Or over 18.
Thank you, Renee. And no other adults 18 or over present with you.
Correct.
Jeanette.
Public member Jeanette here.
Thank you, Jeanette. Jeff Hughes.
Public member present.
Thank you, Jeff. KK Zhao.
Good morning, licensee member present and nobody over the age of 18 in this room. Thank you.
Thank you, KK. Claudia Mercado.
Present.
Thank you, Claudia. Jay Newell.
Public member present.
Thank you, Jay. Ricardo Sanchez.
Public member present.
Thank you, Ricardo. Satinder Sandhu.
Licensing member present.
Thank you, Satinder. Maria Serpa.
Licensee member present.
Thank you, Maria. And Nicole's not joining today, and I am here. A quorum has been established. I truly appreciate everyone's time and commitment to the board and California consumers. I ask everyone participating today to be respectful of the work before the board today. We encourage participation by members of the public throughout our meetings at appropriate times. The board respectfully requests that when comments are provided, they're done so in a professional manner consistent with how the board conducts its business. And before we move to the next agenda item, I would also like to remind board members participating via WebEx to please remain visible on camera throughout the open portion of today's meeting. If you need to temporarily turn off your camera due to challenges with internet connectivity, please remember to announce the reason for your non-appearance when you turn off your camera. Next, agenda item 11, Enforcement and Compounding Committee Report. I will now turn the meeting over to our chairperson of the Enforcement and Compounding Committee, Dr. Maria Serpa. Chair Serpa, the floor is yours.
Thank you, President O. On behalf of the committee, I'm pleased to provide the board with a summary of the committee's efforts at our January 7th, 2026 meeting. Thank you to my fellow committee members, Vice Chair Renee Barker, Jeff Hughes, Sung Oh, Ricardo Sanchez, and Nicole Tebow. First item is summary of discussion regarding possible action to amend Business and Professions Code 4034, 4129, 4129.1, 4129.2, and 4303.1 related to outsourcing facilities. Members, background information on this agenda item is provided in the meeting materials. As you may recall, board members noted during the November meeting that there may be an opportunity to consider technical changes to statutory provisions governing outsourcing. During the January committee meeting, staff provided draft statutory amendments to speak. First thing in the morning, look at, I'm all tongue-tied. During the January committee meeting, staff provided a draft of statutory amendments to specified sections of outsourcing law. Staff is recommending amendments to better align the referenced Business and Professions Code sections with federal definition of outsourcing facility and to harmonize the provisions with other related BPC language. Attachment 1 includes a copy of the draft amendments. As we open for member comments, a motion would be welcome as displayed on the slide. And there it's coming. To authorize staff to move forward to secure these technical amendments. Members?
I make the motion to authorize staff to work with the legislature to secure statutory changes consistent with the proposal presented to the board.
Thank you. Is there a
I'll
second?
second that.
Is that Renee?
Yes.
Thank you, Renee. Any member discussion?
Glad that we're doing it.
Yeah, thank you.
Yeah.
Silence is an agreement, Chair Serpa.
Yeah. With a motion and a second on the floor, we now open the discussion for public comment beginning in Sacramento. Anyone here like to speak? Seeing none, moderator, we're ready for public comment from participants via WebEx.
This is the moderator for members of the public on WebEx. If you would like to make a comment on this item, please click the raised hand icon, or if you're an audio-only participant, you can raise your hand by pressing *3 on your device. And it looks like I have a request from Stephen Gray. Stephen, you'll be given 2 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Good morning, board members and public. Thank you for the opportunity. This is a very important subject, outsourcing facilities. I understand the technical amendments. I think the board should take the opportunity at this time to make another amendment to these sections. Outsourcing facilities by definition are providing sometimes often life-saving or life-affecting medications that are unavailable anywhere else. They're not available from manufacturers. They're usually not available from even compounding pharmacies. They take time to prepare and be able to dispense. And when these facilities are dispensing those to California members and they would suddenly have to stop or they would plan to stop, those members may be at significant health risk without receiving notice. Since they are not pharmacies, an argument could be made that they're not subject to California law that requires pharmacies to give notice when they plan to go out of business or something delay or a long absence of business. So I recommend that the board add a modification to these sections wherever necessary to make sure that outsourcing facilities, whether resident or non-resident, have to give notice if they plan to cease operations like the law requires for California pharmacies, or if they're going to be out of business for a while, maybe to make a facility adjustment or something so that our citizens are protected and can still have time to source these products, perhaps from a sterile compounding pharmacy or some other outsourcing facility that has a license or will get a license in California. Thank you very much.
Thank you.
All right, this is the moderator. It appears there are no further requests for public comment at this time.
Thank you. Members, that was an interesting comment, and I suggest that that be potentially discussed at the committee level. Right now, we're looking at suggested draft amendments just to clean up a language. I would suggest that we kind of separate those two if possible, because these are going to require statutory changes. But I'm interested in your comments. If there are no additional comments,
Maria, this is Renee. Yeah, I would agree with you. I mean, I think we certainly should discuss this, but maybe at the
Renee, we
committee.
can barely hear you. Can we speak
Oh,
up?
okay. Sorry.
Oh,
Can you hear me better now?
Yes.
Okay. Yeah, I mean, it is a point to consider, certainly. But I would agree that would probably be a lot of discussion about what that might look like and what scenarios might be addressed. So I would agree that taking it to the committee level for initial discussion and kind of separating out these two, because they are kind of different functions.
thank you. Any other comments? Okay, if there are no additional comments, I turn the meeting over to President O for the vote.
Thank you, Chair Serpa. Renee, how do you vote?
Yes.
Thank you, Jeanette.
Yes.
Thank you, Jeff.
Yes.
Thank you, KK.
Yes.
Thank you, Claudia.
Yes.
Thank you, Jay.
Yes.
Thank you, Ricardo.
There you go. Yes.
Thank you, Satinder.
Yes.
Thank you, Maria.
Yes.
Thank you, and I vote yes. The motion passes. Back to you, Chair Serpa.
Thank you. Next item is summary of discussion and possible action regarding listening session on CCR Title 16, Section 1707.2, related to duty to consult. Background information on the agenda item is provided in the meeting materials. The committee is interested in gathering further information to assist it in its evaluation of the board's current consultation requirements and to better understand barriers that may limit pharmacist-provided consultation. The committee believes additional feedback from licensees and the general public on these challenges is essential before considering any potential regulatory changes. I want to emphasize that the committee and the board are in the early stages of discussing patient consultation and the duty to consult. During the January meeting, the committee discussed holding a listening session considered potential questions to include. The committee suggested that more than one listening session may be appropriate and also revised and expanded the staff recommended questions. The complete set of listening session questions is available in the meeting materials. After further consideration of this agenda item, I believe that it would be appropriate to hold a listening session for licensees and a separate listening session for patients and consumers, with the questions tailored to each group. As we open for member comments on the motion, we would welcome, as we open for member comments, a motion is on the slide projected. And the slide is to authorize staff to move forward with the scheduling of listening sessions on duty to consult. Members?
Chair Serpa, my only comment is hopefully more than one for licensees because they have a very busy life and hopefully at least 2 or 3. That's all I ask.
So would these listening sessions be conducted at maybe trade meetings as well, or is just sending out a survey and doing possible public meetings?
I think staff could answer that because there are some logistical and legal provisions.
I think historically, when we've hosted listening sessions, they've been conducted via a platform like WebEx or something like that,
I see.
trying to expand the reach as much as possible.
I see. And how about for the public for input? Would that be like anything else, a similar platform, or is it against?
Yeah, I think generally to allow as many people to participate or, to cast the net as wide as possible for people. You don't want geography to be the limitation.
Right.
So generally the use of the technology, I think generally people are used to this space now, after so many opportunities to use it since COVID.
My only concern is that, like with the technology, it's great, we can get the wider net, but sometimes we may be missing out a public that's not on those platforms, and in-person meetings of some sort may be more useful in those scenarios, although I can see that logistically it may be very complicated.
So I think that part of the motion is to delegate to the
Yeah,
chair.
okay.
So if the members are agreeable, at the staff level, we're happy to work with the chair to see the best ways to do it.
Okay.
Including in person, yeah,
Yeah.
right? Satinder, you're hoping
Correct.
for, yeah, okay.
So yeah, we could discuss that further. No, that was it. I just wanted.
I just wanted to make sure also a suggestion to include associations that represent diverse populations so that their perspective is included, representing patients.
Yeah, I would imagine that's the chair and the staff can work with to make sure that we do flag associations who are coming, right? Maria? Yeah.
Yeah, there are, I'm sure that there are some consumer
Interested parties.
organizations that have been involved with the board in the past, and there'll also be a public announcement, but part of that could also be to specifically notify interested stakeholders.
I think I'm gonna make the motion.
So I think did we get a motion?
Not yet.
Okay.
Satinder's about to make one.
Okay. I delegate to the chair of the Enforcement and Compounding Committee to work with the staff to conduct the listening sessions on the duty to consult, possibly tailored to licensing and one tailored to the intended audience.
I'll second that too.
Great, thank you. With the motion and second on the floor, is there any further member comment before we go to public comment? Okay,
Just want to, Corinne, Satinder did not read the last part, authorize the chair to modify listening session questions according to the intended audience.
yeah, that's important.
Oh,
Are you agreeable to including
yeah,
that?
yeah, I'm okay, yes.
The only other clarification is, because I heard people talking about
More
more
than
than
one.
one. So maybe you just want to leave the part about the number out from the motion
Oh,
and
okay.
just delegate to the chair to work with staff.
Yeah, I'll just delegate to the chair to
Not
work with the
limiting it
staffs, yeah.
to one per intended audience.
Yes.
It said word possibly, so I thought that was okay, but
Yeah.
Mhm.
thank you, our
So-
legal counsel.
So that's Satinder's motion. Who was the second?
I'll second.
Ricardo.
Oh,
Fine with that? Okay. And there's no more member comment? Great, we're ready for public comment. Let's begin in Sacramento. Any, excuse me, public comment? Hi, good morning.
Good morning, board. Sean Kim from California Pharmacists Association. We're fully support on this motion, and if anything that we can help with, whether it's stakeholder meetings or spreading the word, or even I would also agree with the board members Tinder about having a different options or modalities. Maybe survey is the way to go, or maybe having a listening session that some people that was available, but we can discuss this further at the committee meeting level and then help with the chairs to support this. So CPHA is fully on board with this. Thank you.
Thank you. Anyone else in Sacramento? Okay, seeing none, moderator, we're ready for public comment via WebEx.
This is the moderator for members of the public on WebEx. If you would like to make a public comment on this item, please click the raised hand icon, or if you're an audio only participant, you can raise your hand by pressing *3 on your device. And I see a request from Stephen Gray. Stephen, you'll be given 2 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Thank you again. This is a very, very important subject. And I want to remind some of the board members that may not be familiar with this or have forgotten, prescription consultation is also required by federal law for all Medicaid patients nationwide. And so participating in this should be someone that represents Medi-Cal for sure, and other Medicaid or federal organizations. Also, when we did this the last time, it was about 20 some years ago, and there was a specific invitation went to the schools of pharmacy to ask them to participate and explain how they teach prescription consultation. And some of them showed up and they talked about how to communicate, but they misunderstood the invitation and didn't inform the board about how they taught how to do prescription consultation at the front counter. I believe a specific invitation should go out to all the schools of pharmacy in California. There are some that did not participate then because they didn't exist back then. So that would be very important. Also, ISMP and some of the other quality organizations have done studies on this, or hopefully have done some studies that should be looked into. And the University School of Pharmacy, Southern California, USC School of Pharmacy, in cooperation with Kaiser Permanente, did a $2 million 2-year study on the value of prescription consultation, which proved its value. And that study is still available. And I believe you could contact the School of Pharmacy. And the professor involved at that time was Jeff Combs, I believe. And that also would be important to show the value of that study. It was a controlled study, and it was very well done.
10
And
seconds.
as far as I know, it's the only one that was ever done at that level in the United States. Thank you.
Thank you.
All right, this is the moderator. Appears there are no further requests for public comment at this time.
Great, thank you. If there are no other member comments, I turn the meeting over to President O for the vote.
Thank you, Chair Serpa. Renee, how do you vote?
Yes.
Thank you, Renee. Jeanette?
Yes.
Thank you, Jeanette. Jeff? Thank you, Jeff. KK?
Yes.
Thank you, KK. Claudia?
Yes.
Thank you, Claudia. Jay?
Yes.
Jay. Ricardo?
Yes.
Thank you, Ricardo. Satinder?
Yes.
Thank you, Satinder. Maria?
Yes.
Thank you, Maria. And I vote yes. Motion passes. Thank you, Chair. Back to you.
Thank you. Next item is summary of discussion and possible action regarding proposed frequently asked questions related to the board's regulations on compounded drug preparations. Background information on this agenda item is provided in the meeting materials. Staff is proposing new FAQs related to the board's recently approved compounding regulations that took effect October 1st, 2025. Attachment 2 includes a copy of the proposed FAQ. You will note that the committee is offering a recommendation to approve the proposed FAQs, including minor edits suggested by the committee. With the committee's recommendation serving as the motion, members, do you have any questions or comments on the proposed FAQs?
Hi, Chair Serpa. This is Renee. I just wanted to say that the further edits that were made look excellent. I feel like it's just a really good format, and I think the content will be very helpful for the public.
Thank you.
I also would provide a motion if there's no more discussion.
The motion is from the committee, so we're okay, Renee.
Okay. Okay, good.
Also wanted to remark for the record that that Renee was also instrumental in reviewing the draft FAQs that staff proposed as vice chair, and our compounding pharmacist. Seeing no more public member comment, I think we're ready for public comment. Any comment in Sacramento? Seeing none, moderator, we're ready for public comment via WebEx.
This is the moderator for members of the public on WebEx. If you would like to make a public comment on this item, please click the raised hand icon, or if you're an audio only participant, you can raise your hand by pressing *3 on your device. All right, and it appears there are no requests for public comment at this time.
Thank you. If there are no additional comments from members, looking around.
Just really quickly, I just want to thank you both for your hard work, Renee and Chair Serpa, for this important document, because there was so much confusion in the past with the compounding regulations and with those changes. You know, having a clear path forward is so important. And so anything that can be done to make it smoother and more clear, you know, my hat's off to you guys for your hard work on this, for sure.
Thank you. I think we're ready for the vote, President O.
Thank you, Chair Serpa. Renee, how do you vote?
Yes.
Thank you, Renee. Jeanette?
Yes.
Thank you, Jeanette. Jeff?
Yes.
Thank you, Jeff. KK?
Yes. Yes.
Thank you, KK. Claudia?
Yes.
Thank you, Claudia. Jay?
Yes.
Thank you, Jay. Ricardo?
Yes.
Thank you, Ricardo. Satinder?
Yes.
Thank you, Satinder. Maria?
Yes.
Thank you. And I vote yes. Motion passes. Back to you, Chair.
Thank you. The next item is summary of discussion and possible action regarding updates to community pharmacy self-assessment hospital outpatient pharmacy self-assessment. Members, background information on this agenda item is provided in the meeting materials. I am pleased that with the passage of AB 1503, the self-assessment process is now centralized in statute. Yay, this is really good. Thus allowing, I have to make some editorial comments, thus allowing the board to streamline the annual process. As you may be familiar, in the past, sometimes annual processes would step on top of each other because they took so long that we were reviewing self-assessments 2 and 3 years down the line with various iterations. This will make the process a lot more streamlined and more productive for the board. As a part of the current annual updates for self-assessment, the board is taking an opportunity to not only update the contents of the community pharmacy hospital outpatient pharmacy self-assessment form to reflect the new laws and regulations, but also to revise the format of the form for ease of use by the regulated public. The board plans to revise all self-assessment forms to a similar format, and each form will be discussed at future committee meetings. Attachment 3 includes a copy of the proposed community pharmacy hospital outpatient pharmacy self-assessment. You will note that the committee is offering a recommendation to approve the revised format along with the updated contents to the self-assessment. With the committee's recommendation serving as the motion, I invite members to share any questions or comments on the revised format first or together and the updated contents to the community pharmacy self-assessment hospital outpatient self-assessment. Members, any comments?
Hi, Chair Serpa, this is Renee. I just wanted to say that I think this document, this update is excellent. I think it's much more user friendly with a reference table of contents. It's very clean, and I think having the regulatory references as links to each topic, it's just, I think, becomes a really good way for the self-assessment and for any learning. So just thank you to staff for their work on this.
Thank you.
I second that. It's really makes it a lot easier in the format it is to navigate. The only concern I have is that I hope that person doing the assessment would click on all those links and for reference, because in the past it was easy in there, but it made it really extremely long. It was 50 some pages. But this is I love the format. So
Great, thank you. Any other member comment?
Just have one ask for our staff which is, I think it's nothing to do with the motion. I'm sure they can be done. On the website, we still have the draft and adopted forms. Hopefully we can just leave them there for about a year or so for the transition, at least for this form. And then just clarify that on the website, what are the triggering events for people to do other than July 1 of every odd numbered year on the website.
Go ahead, Anne, because I think there's some.
Yeah, I think
challenges
we'll
with that.
probably need to consult with council afterwards because of the transition and now the board approval. It might create some clarity issues, but I'll totally work with.
Okay.
I say I mean we, Julie and I will totally work with council, and to the extent that's possible, we'll explore it.
And maybe explaining what's going on if like just
Maybe,
on the website.
and part of the discussion is, I think you used the word draft, and once after our vote today, this will no longer be draft. So the other one is the old version, and then we have the current version. So maybe referring it to that way in our discussions would be helpful. Okay, any other member comment? Seeing none, we're ready for public comment in Sacramento. There's no caffeine in the room. Moderator, we're ready for public comment via WebEx.
This is the moderator for members of the public on WebEx. If you would like to make a public comment on this item, please click the raised hand icon. Or if you're an audio only participant, you can raise your hand by pressing *3 on your device. And I have a request from Stephen Gray. Stephen, you'll be given 2 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears in your device.
Thank you very much. I also strongly support the use of the self-assessment form, and the new format looks very good and should be a lot easier to use. I want to comment that this is a key item for pharmacists that are intending to take the law exam, and they use this to study and to learn. And the professors of pharmacy law and ethics at the schools also use it to outline their courses. So it's going to be very helpful, especially to have all of those referenced. I do note that there are a few content changes that are not highlighted, and I'm wondering if it would be helpful. I support the motion, but it would be helpful if the board could produce a kind of something like today's law as amended type thing, because I noticed that there are some things that have changed that may reflect to changes in board policy. For an example, in this self-assessment form regarding prescription consultation, there's no reference to black box warnings. In previous self-assessment forms, the board basically explained that a black box warning is by definition a severe adverse or potential reaction that had to be covered in a prescription consultation, and it's not listed here. And it is things like that make me a little nervous that we don't know what was changed or what was left out or added when we have an update like this. Maybe it's something that could be handed over to the communications committee or something to identify how this changes board law and interpretation. Thank you.
Thank you.
All right, this is the moderator. Appears there are no further requests for public comment at this time.
Great, thank you. Members, any further comments? Okay, seeing none, I turn the meeting over to President O for the vote.
Thank you, Chair Serpa. Renee, how do you vote?
Yes.
Thank you, Renee. Jeanette?
Yes.
Thank you, Jeanette. Jeff?
Yes.
Thank you, Jeff. KK?
Yes.
Thank you, KK. Claudia?
Yes.
Thank you, Claudia. Jay?
Yes.
Thank you, Jay. Ricardo?
Yes.
Thank you, Ricardo. Satinder?
Yes.
Thank you, Satinder. Maria?
Yes.
Thank you, Maria. And I vote yes. The motion passes. Back to you, Chair Serpa.
Thank you all. I think in the future, you will be seeing the additional self-assessments come through over the next few months. I think it'll be pretty quick in updating all the self-assessments to be in the new format. Appreciate everyone's assistance on that. Next item is summary of discussion of enforcement statistics. The meeting materials include a summary of enforcement statistics for the first 3 months of fiscal year 25-26. The board has initiated 1,857 complaints and closed 1,505 investigations. As of December 31st, 2025, the board has 1,883 field investigations pending. The materials provide a breakdown of the average time frame for the various stages of the field investigation process. Attachment 4 include the enforcement statistics. Members, I welcome your thoughts on the statistics provided.
Any reference in terms of any outliers that you guys are seeing? I know we mentioned we were getting more complaints because we think that people are using technology to kind of facilitate that, but anything that stands out that we should pay attention to? Anne or anybody?
I think we look like we are trending up a little bit. It's a little bit hard to tell with just 6 months of data. So we'll probably definitely at the end of when we do our 3-year comparison, we'll definitely be able to see some trends, but it does look like we are trending up in terms of the number of consumer complaints that are received. So there's a variety of different triggering events for investigations. We are noticing an uptick in complaints received specifically by consumers. But like I said, it's 6 months worth of data. So it's hard to tell if it's, an overall trend or just, an anomaly for this period of time. So we are at the staff level, absolutely evaluating that and monitoring it.
And for the field investigations, do we have the staff to do the field investigations or, because I know there's about 1,883 pending.
Yeah.
Is that just because of time that it takes to investigate each case that it kind of?
Yeah. So, all investigations, we have our field that do it, and those are all licensed pharmacists, and then we have desk investigations. So the field investigations are those that are being done by pharmacists. It requires pharmacist knowledge, et cetera. Those generally take a bit of time to do. There's a lot involved in it, and really some of it does depend on the nature of the investigation. So there are some types of investigations that can be conducted pretty quickly. There are others like things involving like potential allegations of fraud or compounding or those kinds of things where the scope of the investigation is much broader. And so the investigation time takes a lot longer, if that makes sense.
Yes. And are we capturing that in any report, like how long these pending cases have been with us?
So we do try to give you snapshot of how long it's in the various buckets by average time.
That's
We
right.
do not in here break it down by team.
That's right. Okay, thank you.
And I think also for the public and for new members is annually we have a presentation on the enforcement process, and that's very much broken down into the detail. It is available on WebEx. Do you remember what month that is, Anne? That you and Julie made those
I
presentations?
think we gave it last in June.
Yeah. So June has a very detailed annual review of the enforcement process and the statistics. It's very helpful to review.
Okay, thank you.
Oh, and without any other member comment, we're ready for public comment.
Morning, board member again, Sean Kim from California Pharmacists Association. As we are observing this number is kind of expected as well. As I have commented previously, since we had the Rite Aid closures, there have been much of the patient shifting around to neighborhood pharmacies, and then that causes much more inventory issues or cash flow issues for pharmacy to stock properly, as well as the quota issue with the wholesalers. And things that I also want to put it on your radar is there has been a lot of updates in terms of practice, especially in 2026, regarding federal sponsors programs like Medicare with MTF programs, which includes a lot of cash flow issues for top 10 drugs that is discounted for Medicare Part D drugs, as well as the Medi-Cal population has changed so much in terms of the coverage issue. So January is very chaotic time for not only the pharmacies, but also for the beneficiaries of the people that who are covered for whether they're employee-sponsored programs, but also the government-funded programs. So please give some grace on this as you are inspecting those. There will be more as we're expecting. I'm cautious to see how the January will plan out, but just want to put that on your radar. That's the reason why we're seeing the number increase. Thank you.
Thank you. Any other comments in Sacramento? Seeing none, we're ready for public comment for individuals participating via WebEx.
This is the moderator for members of the public on WebEx. If you would like to make a public comment on this item, please click the raised hand icon. Or if you're an audio-only participant, you can raise your hand by pressing *3 on your device. All right, it appears there are no requests for public comment at this time.
Great, thank you. Members, any further discussion or additional comments? If not, thank you for your time and attention. President O, I turn the meeting back over to you.
Thank you, Chair Serpa. Appreciate it. Always. Thank you for all the work you do and the committee work. Next agenda item is agenda item 12, licensing committee report. As a chair of the licensing committee I am pleased to provide a report from the committee's meeting earlier this month. As demonstrated in the meeting materials, the committee had a very long and productive meeting. Thank you to my fellow committee members, Satinder Sandhu, Renee Barker, Jesse Crowley, KK Jha, and Claudia Mercado. First is summary of presentations and discussion of proposal to establish definitions for pharmacies based on business model. During the committee's meeting earlier this month, the committee continued its consideration of a proposal to establish definitions for various pharmacy business models. As we have previously discussed, the requirements for pharmacies generally apply equally among a variety of pharmacy business models unless the law explicitly specifies otherwise. While this approach allows for broader regulation, it can become challenging when requirements may not be applicable to a specific pharmacy model. In some cases, could create a barrier to patient care. There's a lot of background in the meeting materials that I'm hopeful members have had an opportunity to review. As noted in the meeting materials, during the committee meeting, members received presentations on 3 pharmacy business models: outpatient infusion centers, home health services, and skilled nursing facilities. These presentations were very informative, and I would strongly recommend members review the presentations included in the live stream of the meeting if you have not had opportunity to do so. The presentations, I believe, also underscore the importance of this discussion by the committee. This includes, for example, the requirement to maintain an area for consultation within the pharmacy, even for business models that do not include direct patient dispensing. As the meeting materials indicate, the committee is not offering recommendations at this time, as we believe additional consideration and development is appropriate. The materials do include proposed definitions being considered by the committee so that our members can comment any additions or anything that we think should ponder on about. So please, members, any thoughts on the draft definitions that we have as a starting point?
Hi, Chair O. This is Renee.
Thank you,
I
Renee.
think I would look at the definition of chain community pharmacy, in that, just in terms of the definition, that the word chain. So a chain community pharmacy is community pharmacy that's part of a chain of 75 or more, and wondering if that can be like wordsmith to not describe, when you're looking for the definition and it's still the definition of like a chain, like a network, something like that. Or if it's just part of 75 or more stores in California under the same ownership.
Oh,
It's a little tricky with that one because that one is already in our law somewhere. So
I see. Okay.
we'll consider the comment and see what we can find out for you.
Well, I mean, community pharmacy, we have the definition. Doesn't that also apply to chain community pharmacy with the add-on of 75 or more?
mhm.
Community pharmacy is a pharmacy that dispenses medication to the general public, or a chain community pharmacy is part of a network of 75 or more stores. Is that what Renee's?
Mhm.
So do we repeat the wording? Am I making
Yeah, I
sense?
see what you're saying though, with the, it's already in the regulation as defined that way. So I don't know, we might have to figure out. So I don't think it's a huge change. That's not how we usually define something, but if it's already in the statute, then I think there's another hurdle there, right?
Yeah. Okay. Anyone else? Maria?
Yeah, I wanted to thank the committee for the discussion. I think it's very challenging because it's not like there's a clear line between the different types of pharmacies. And in fact, some pharmacies provide different services that cross over. So they are involved with more than one type of service. So these seems to be more like service descriptions than pharmacy descriptions. And I look forward to the committee's discussion on that. 2 areas I think that could use some more discussion, and I know there was a presentation on it, is infusion center pharmacy and home infusion pharmacy. I'm familiar with the infusion center pharmacy more than the home infusion, but I have been around those types of environments. And I would suggest that the committee have a lot more discussion on the scope, because there is so much more that happens. An example is like an infusion center pharmacy is usually affiliated or nearby or associated with an infusion center place where they actually administer the medications. And as such, the infusion center pharmacy is the supplier of all the medications to that location: oral medications, injectable medications, supplies, syringes, all sorts of stuff could be from there too. And controlled substances is a big deal in infusion center pharmacies, going to the infusion center. So those kinds of things I think should be discussed to assure that the definition is clear and does not cause confusion as to limiting the scope of what's authorized. home infusion pharmacy, similar, but it's not going to another healthcare professional to administer. Typically, sometimes a nurse does administer at home, but they do also provide a lot of supplies and sometimes other medications other than sterile parenteral medications, or you didn't use the word compounded in either one of those. So I thought that was fascinating because not all medications are compounded. Some of them are pre-manufactured. So I look forward to the discussion of the committee more on those two areas.
Thank you, Maria. As you guys can imagine, this is this is a complex topic for sure, and it can get very hairy. So, but at least at the committee level, just want to provide a little background from our discussion was that we are hoping that this is not this is more of a self-determination. So of PIC or whoever, most likely PIC, would be determining for their own self-compliance based on these models, so that it will be their own determination and exempting out based on how we would be legally providing that pathway for them to exempting out, so that it's not like, oh, you determine yourself to be this so that you cannot be doing this. It would more be of, oh, I think my business operates in these fashions, therefore that I fall into this category, and therefore that hopefully then I don't have to follow labeling requirement or
Right.
posted notice,
Mhm.
so that it's more of a self-determination, not a you are certifying to be this business, therefore you cannot be performing anything else.
I understand that. I think also when you get down to actually finalizing a document or materials, I'm a little concerned with actually the titles being called a pharmacy in every section, because they're really not the pharmacy, it's the service. So it's
Good point.
complicated. So I'm sure the committee will have a lot of discussions.
Very complicated, yes.
I totally agree. It's very complicated. Just the community pharmacy definition itself, you have a independent pharmacy that's in the regulation 4 or less, and then you have a chain pharmacy 75 or more, and what happens to the one that are in between. So it's challenging when you're trying to define, even though they provide very similar services.
We could add a pharmacy that is between 4 and
Yeah.
75. So it
Agree.
could be a moderate, I don't know, in between pharmacies.
Yes.
So if you'd like to proceed that route, we could also add that into our definitions. I don't know what purpose, but we
No,
can.
I don't think it serves any purpose. So
So yeah, this is definitely a complicated area. KK, I know you are also in this space a lot, so I don't know if you want to add anything there. So just want to provide you the opportunity. Renee, I want to make sure you're okay with the specialty pharmacy where we landed. And anyone else, any comments?
No, I'm pretty good with what we have here, and Ms. Dang also provided some very good presentation that day. No comments.
Thank you, KK. Just so everybody's aware, also, the hope for this is to remove barriers and not to complicate further. So hopefully, if things get more complicated, that's not the intention. This is too, so that our licensees and regulated public does not feel there's a less barriers to care for things that may or may not be really relevant to their practice models. So that's the goal. So hopefully that makes sense. Okay, well, with that, I'm going to go for public comment in Sacramento. Dr. Kim?
Thank you so much for the discussion. I completely agree with Dr. Serpa's points of what service rather than what type of providers or what type of pharmacy, because we should think about the essence of standard of care model, right? It always goes back to the standard of care that we have a framework on, and how we operate is there's the best practice model that we should keep on point of. As we are evolving over time of pharmacy practice, whether you provide immunization from your pharmacy or HIV PrEP or smoking cessation. It's gonna continue that this pharmacy does specialty pharmacy at the same time they also provide CMM at their pharmacies. It's hard to define because they exist in this facility and they name themselves as a specialty pharmacy, then we're getting back into the rabbit hole of like, okay, let's define it. What is specialty pharmacy? So I'm excited that we're going to have more conversation about this in a committee level. However, I just want to bring it up to the attention that we should focus more on the services that the licensees are providing rather than hiding themselves into a specific definition of this is what inpatient or outpatient clinics or specialty pharmacies, because at the end, they can be all of them. So just want to add the comments. Thank you so much.
Thank you.
Thank you, Dr. Kim.
Good morning.
Good morning, Lori Walmsley on behalf of Walgreens. Just to elaborate a little bit more on what Sean said. First of all, I appreciate the conversation. I think that it's well needed. Although I do caution the board, like Sean mentioned, in creating too many different categories. Pharmacy practice continues to change, and I think an alternative ways that you could look at maybe creating general frameworks for certain things. Like if you dispense drugs, these are the things that you need to have, kind of more of a standard of care approach to the regulation. Because I think you're never going to be able to encapsulate everything. And like Sean said, also many pharmacies can be multiple things, right? So then which category do you fall in? Is it whatever is your primary business? How do you determine what the primary business is? So I think that, it's a great conversation and look forward to continuing to participate, but I caution you in making it more complicated. I think that your intent is definitely a good one and definitely necessary, but I think that there's maybe a different approach that we could take.
Thank you for the comments. Okay, we're gonna go for public comment in WebEx.
This is the moderator for members of the public on WebEx. If you would like to make a public comment on this item, please click the raised hand icon. Or if you're an audio only participant, you can raise your hand by pressing *3 on your device. And it looks like I have a request from Stephen Gray. Stephen, you'll be given 2 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Thank you. I completely agree that trying to establish definitions is very complicated. And we always have to remember that the two basic fundamentals of law are definitions and jurisdiction. In other cases, we've seen definitions established and then added a phrase for the purpose of, and sometimes that helps clarify it. I also agree that there are definitions in statute. I noticed there's a couple that are not there, that hospital pharmacy is not there, remote site dispensing pharmacy, and so forth. And those have very specific statutory requirements, et cetera. Also, hospitals, for an example, are allowed to dispense to the general public a certain percentage of their prescriptions. And so, it gets very complicated, but I encourage. There's also some definitions that are used at the national level by the Council on Prescription Drug Classifications and other organizations that you might want to take a look at. And that's important because those are used at the federal level to establish certain requirements. And, you may confuse the legal issues by adopting what looks like an identical definition, but in reality, you meant something different. So those are my comments. And, I want to say to the committee, good luck on this. It's very difficult. Thank you.
Thank you, Dr. Gray.
All right, this is the moderator. Appears there are no further requests for public comment at this time.
Thank you, Sarah. As the public comments you can be heard here, this is why I myself was very hesitant to bring this topic for many years, and been very hesitant to tackle this. But again, so let's just provide some reminders that, one, you this is the intent is not to put you in a rabbit hole that you will only belong. It is you're self-certifying so that you may or may not have to follow certain rules and regulations is the intent. So hopefully that makes sense. So if you fall into a closed door pharmacy, maybe we could find a way that those folks don't have to create a area that is required for confidential patient consultation or follow a certain rules and regulations such as posting a notice. So that's the intent again. So nothing would preclude you from falling into multiple models. So I hope that makes sense. And with that, I'm opening up for member comments one more time before we move to the next agenda item. Members? And we can just say, I don't like this, stop doing this. I don't mind this. I mean, I'm trying to help out here, but this is not to try to complicate. This is not to try to complicate. This is to make things easier for our people so that they can take care of their patients and not focusing too much on unnecessary things that does not serve patient care.
I have a question. So why did we leave can we explain to the public why we didn't include the hospital pharmacy definition?
I think it just was more focused on a non-hospital pharmacy was our focus. So just to go back even further, so our pharmacy license types are really limited to a PHY, which is non-hospital pharmacy, and HSP, which is hospital pharmacy. Really, those are the two license buckets. And when it's PHY is where things get very broad. So you could be an infusion center pharmacy, but it's a PHY if it's not in a hospital. You could be a closed or long-term care pharmacy, they're PHY. You could be a chain community pharmacy or a PHY. You could be a mail order pharmacy or PHY. But what we determined at the committee level, at least we're not able to decipher the license type because then it gets even more complicated as the public comment says, then you're really putting yourself into that hole, right? If you decide you're a mail order pharmacy and that's your license type, then you're really a mail order pharmacy, right? Then what if someone comes to your pharmacy and you open their door like, oh no, I cannot give it to you. I have to mail it to you. So even though you're right here, I'm going to mail it to you, right? Those are the scenarios that I'm like probably being a little hyperbolic, but just kind of, an example, right? So that's why we decided not license category, but a definition of a business model so that a business, and we determined at the committee, it would not be such an enforcing, like, this is the business model, then you must do this. We're not hoping for that. It's more of a self-determination of, okay, I am this is the patient population that I service. So therefore, I no longer have to follow certain rules that used to fall into everybody when it was, our current model, right?
We're also trying to make it more efficient for them so they don't have to
Yes.
comply to things that don't
That's the
apply to
idea,
them.
yes.
Yeah.
That's the intent and idea. And I apologize to the public, to everybody. I know that this probably is a little nerve-wracking because I understand because this is a complicated area.
Oh, thank you.
So
Appreciate
thanks,
that.
Dr. Gray, for your wishing us the luck. Appreciate it. We need it. Any other comments? But I suppose nothing harmful to add hospital pharmacy into our definitions, just to clarify, that's already out there in the statute.
Oh, I think you answered the question very well. And maybe in the introductory statement is to say these are the services provided by PHY. And that would
Not
be like the
HSP.
place to start. Once you start putting acute care, then you just open up a new bucket.
Right, then with it, yes.
Just like you said, it's really articulated to make it easier for the public. Like there's some things like if you don't see consumers, what is the use of consumer poster in that setting? So it's your self-determination. It's, like allows some flexibility, I think is the intent. So I agree with that,
Thank you. Okay, more to come, obviously. Okay, so we'll still proceed very cautiously and we'll see where we land. Hopefully we'll have some statutory language we will be able to get out to you all in April or June. Okay, next is summary of discussion of pharmacy practice experience requirements pursuant to Business and Professions Code Section 4209, including possible action to approve a draft policy statement and draft statutory amendments to BPC Section 4114 regarding pharmacist to intern pharmacist ratio. As the meeting materials reflect, look at us just breaking down all the ratios. Pharmacy law establishes a requirement for an intern pharmacist to complete 1,500 hours of pharmacy practice experience before applying to take the pharmacist licensure examinations. The statute further provides that an applicant that has graduated after January 1st, 2016, from an accredited college of pharmacy is deemed to have satisfied the pharmacy practice experience requirement. The meeting materials also include information on the updated ACPE standards that all accredited pharmacy school programs must satisfy. This includes completion of introductory and advanced pharmacy practice experience. As I noted during the committee meeting, the standards establish rotation requirements and require completion of a total of 1,740 hours of experience. The board had received comments suggesting that the board should reestablish a requirement for an intern to complete internship hours outside of the practice experience gained as part of their pharmacy education. During the meeting, the committee continued its discussion on this important topic. As you may recall, during the November 2025 board meeting, members noted the value in interns gaining experience outside of the experiential training received as part of their pharmacy education. But members noted some of the challenges students may experience in trying to secure outside employment, in part due to limited availability of intern positions. Members also considered if there is a way to incentivize employers to create additional intern positions. During the committee meeting, members reviewed a draft policy statement intended to be used as a means to convey the board's support for interns gaining experience outside of the experiential training earned through pharmacy education. As a committee, we agree with the draft policy statement. In addition, during the meeting, members considered if the current pharmacist to intern pharmacist ratio established in Business and Professions Code Section 4114 could also create a barrier to establishing intern pharmacist positions. As a committee, we concluded that changes to Section 4114 are also appropriate. Just want to draw your attention to Attachment 1 that includes both the draft policy statement and statutory proposal. So you'll note that the proposed change in Section 4114 would remove the ratio, pharmacist to intern ratio, as drafted right now, while discussion at the committee discussed potential amendments to defer the decision to the PIC in the language itself. I, at this point, believe straight removal of the ratio is more appropriate with the silence of the language, inferring that the PIC is responsible. This is determined to be more appropriate as many preceptors are not PICs and therefore would be difficult to operationalize it. And it would be understandable, though, if members would like to put some guardrails, but at this moment, I do not believe having ratio for interns have much purpose. So looking forward to your thoughts as well as input from the public comment. Members? Taking silence as agreement. Maria?
I don't want to be the first one to speak. I speak in support of removing the ratio on interns. I think that that certainly played a part in our history of the practice of pharmacy, but that's no longer applicable. Thank you.
Thank you, Maria.
Well, I want to mention that we did talk about the barriers for interns. So if we can just address that briefly, what we found at the committee level.
There's a multitude of things, but I think one is location, two is time. A lot of pharmacy schools do have we have 14 pharmacy schools, I believe. So a lot of pharmacy schools now have accelerated programs, and I think that's definitely a barrier. So people who have a very year-round schooling and they're, trying to get a job outside of that is not easy. Positions are not that, there's not a lot of positions out there. So it's hard to find a job. I know oftentimes, anecdotally, I have, I'm in San Diego, so I have one school, so it's easy for me to kind of gauge. But I know a lot of interns who say that, it's a very competitive process to get a job. So, we're possibly thinking it's a ratio issue, right? Because only one pharmacist can have two interns at a given time. So if it could be more, maybe there's at least one step of removing barriers.
Thank you. Yeah.
The one in the WebEx, anything, Renee or KK, just so that, you know, you don't feel like you're left behind there in the world of technology? All right.
Yeah, this is
Okay.
Renee. No, I would agree. I mean, I think that removing the ratio, while it may not be a huge leap forward, but it definitely would remove a barrier if that's a barrier in some locations, right? Because I think there's still, a lot of limitations for the proximity of an intern position to a school, that type
Yep.
of thing.
Budget,
So I think it's
money,
great. And
yep.
I just wonder, I completely agree with trying to go to the kind of standard of care, the PIC, what you said, right? About not specifying that the PIC has to name it, but I'm just wondering like how that education could go out. So, I think that might be a question as there's a transition in thought about how many interns can we have, right? So anyway, I'm just throwing that out. I mean, I would agree with that. I think moving forward, it's going to be, can be determined at the local level, but just by removing it, there may be questions.
Yep, I agree. I hope some pharmacies doesn't start hiring like 10 interns and just, have 1-to-10 ratio or something. But hopefully, our pharmacists would use their professional judgment and not do such a, well, I mean, I guess they could if they feel like they can handle it. So I don't know. That's where our members share your thoughts on that. I mean, should there be some ceiling?
I think if we trust them to go with the standard of care and make professional judgments at all times, and I think it's definitely appropriate for them to be making ratio decisions based on the local environment. I mean, it's dictating what the ratio should be when you don't know the individual setting. It just doesn't make any sense. And Maria Bryant had pointed out that it's our history of our pharmacy, but I don't think it's no longer applicable.
Mhm. I think just to educate public and our public members too, is that intern pharmacist licensure is not a forever licensure. It's a very limited, there are requirements to be in a school or limited after graduation. And it's typically a pathway to licensure as a pharmacist. So as an employer, it would not be to my benefit to hire a lot of interns just so that I could rotate them every year. I'd rather have a really good, well-trained technician staff that are going to stay with me for a long time.
Thank you. Anybody wants to make a motion?
I'll make a
I'll
motion.
make an
to
attempt.
Accept the recommendation.
You have to read it.
Approve the draft. Oh, here, I can do it from here. Approve the draft policy statement either as presented or consistent with the board's discussion. Sponsor legislation to amend Business and Professions Code, Section 4114, either as presented or consistent with the board's discussion.
So we'll just stick with consistent with the board's discussion. And then as presented, right? Ricardo is okay. Policy statement as presented. Okay. And then do we have second? Satinder?
I'll second.
Thank you, Satinder.
It was right there.
All right. We're ready for public comment. Dr. Kim?
Sean Kim from California Pharmacists Association. Thank you so much for the discussion. We fully support getting rid of the ratio parts as we are evolving to different era of pharmacy practice. It makes sense with the standard of care, and it'll be shown like how many will be the appropriate, depends on the pharmacy practice settings and how well established for that institutions and the pharmacy with the training. I think it really ups to the pharmacists who are working there as a preceptors. Some of the challenges, as the member Mercado mentioned, which I have also addressed from the previous meeting, is that not only the intern pharmacist, but also we need to invest into the high quality of preceptors, which has to be aligned with the incentives model. As you know, how the system has been built on is misaligned with how the patient outcomes comes derived from. So for instance, like right now we've been talking about fee-for-service model to value-based care model to improve patient outcomes. But what I'm trying to say here is that if there is not such incentives for having the public to invest into the future of pharmacy profession through the intern pharmacist, then there is a lack of motivation for the preceptors and as well as the employers to invest into the public education or the training to help having the high quality pharmacist that who will be practicing in the future. So therefore, we should think about how we can incentivize the folks that who are going to be in charge of training the intern pharmacist as a future of pharmacists, such as continuing education or other incentive models that we should be thinking of. Thank you.
Thank you for the comments, Dr. Kim.
Good morning again, Lori Walmsley on behalf of Walgreens. I really appreciate the discussion of the board and think that this is certainly a great move for the future. Hiring interns and a variety of positions that I've had before, usually the pharmacies that are located closest to the pharmacy schools or the locations that everybody wants to work at. Some students have transportation issues, those kinds of things as well. So I think that this certainly will give the opportunity for interns to potentially have more opportunities to work, which could help with some of the student loan issues, their ability to have additional monies to care for their families and all those kinds of things, as well as, most importantly, providing them with additional actual practical experience, which should increase their confidence to move into practice more readily, as well as hopefully pass the exams a little bit more quickly. So on behalf of Walgreens, we certainly support this direction. So thank you.
Thank you for the comments. Seeing no other public comment in Sacramento, Sarah, we're ready for WebEx.
This is the moderator for members of the public on WebEx. If you would like to make a public comment on this item, please click the raised hand icon, or if you're an audio-only participant, you can raise your hand by pressing *3 on your device. I have a request from Stephen Gray. Stephen, you'll be given 2 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Thank you very much. Can you hear me?
Yes.
Thank you very much. Getting a little feedback here. I strongly support this statutory amendment for all the reasons stated by the previous speakers, but also because when the ratio was discussed and created back in the mid-90s, it was all about the interns that worked in pharmacies and hospitals. And that is no longer the situation. We now have what are called IPPEs, initial pharmacy practice experience, and APPEs, which are advanced practice experience. And those are often AmCare rotations that are not inside a hospital or a pharmacy. And the ratio has caused a lot of confusion about whether that ratio actually applies in those situations. And so by removing the ratio, it opens that up. And it's very important, as was explained, that we increase the training in APPEs, especially going to the standard of practice, where a lot of pharmacists now, that's where they get their practice standards for clinical practice. They may come back and work in a pharmacy or a hospital, but often they get it in a non-pharmacy, non-institutional licensed location. Also, it clarifies when pharmacy interns go out and work with pharmacists in a health fair or something, about how many pharmacists have to be on duty before you can have the students come out and participate in health screening or some other professional activity. And this will help in that situation. And then finally, just a comment that the ACPE standards, if you read them specifically, do not allow the experience to be gained by a pharmacist who's getting paid.
10
So,
seconds.
so that is a big problem with a lot of confusion among all of the schools. On the East Coast, the schools pay locations for the site experiences. That's not prominent on the West Coast, but for over 50 years, it's been prominent on the East Coast for schools to have to pay for experiential rotations. And then they just pass that on to the students as far as tuition costs. Thank you very much.
Thank you for the comments, Dr. Gray.
All right, this is the moderator. Appears there are no further requests for public comment at this time.
Thank you, Sarah. Thanks, Dr. Gray, for serving as an unofficial Board of Pharmacy historian. I love your history lessons. I tell you, it's fascinating. I didn't know that that was back in 1996. So good to know. Members, any comments on that?
I have a question. So for the ratio, so for example, any pharmacy needs to have a 2-to-1 ratio, but what if that intern is not working? So you have to hire, even if they're not actually at the job site, you can only have 2. I mean, that was the old ratio, or is it, can you have 4 and then 2 working at a time?
So I'm saying this as a practical world, not a legal advice.
Right.
So in practical terms, we would in general not have more than 2 people if there's
Hired.
only 1 pharmacist.
Got it.
Right?
Okay.
So, but if there's 2 pharmacists, that's different. But if there's only 1 pharmacist at that given time during that day, if there's only 1 pharmacist, we would not have more than 2 interns scheduled.
Yeah, so you can have payroll for, let's say, 10, but only 2
Right,
at
only
a
2
time can
people
actually.
would be allowed to work,
Okay, understood. Thank you
right,
for
in
clarifying.
that site.
Good.
But there's, as Dr. Gray says, the sites are evolving. There's so many different, there are a lot of
Exactly.
practices. I mean, which in my opinion, don't kick me under the table. I don't think those sites would have fallen into this ratio in my wild, but hopefully
Okay,
it wouldn't matter anymore because we're getting rid of the ratio.
right. Understood. Thanks for the explanation.
Okay, ready for vote, members? All right. Renee, how do you vote?
Yes.
Thank you, Renee. Jeanette?
Yes.
Thank you, Jeff.
Yes.
Thank you, Jeff. KK?
Yes.
Thank you, Claudia.
Yes.
Thank you, Jay.
Yes.
Thank you, Ricardo.
Yes.
Thank you, Satinder.
Yes.
Thank you, Maria.
Yes.
Thank you. And I vote yes. The motion passes. Next is agenda item C, but it may take a little bit long. So we're going to take a quick 15-minute break. Well, 15-minute. Yeah, I think we have to do 15 minutes, right, Ann? Yeah, okay. So we'll come back at, we'll have to come back at 10:33. Okay, 10:35. Okay, let's do 10:35. All right, 10:35.
Wow. Very dynamic.
Okay, Renee, are you back?
I am.
Thank you, Renee. Jeanette? Jeanette?
Yeah, I'm here.
Thank you, Jeanette. Jeff?
Present.
Thank you, Jeff. KK?
Present.
Thank you, KK. Claudia?
Present.
Thank you, Jay.
Here.
Thank you, Ricardo.
Here.
Thank you, Satinder.
Present.
Thank you, Maria.
Present.
Thank you, and I'm here. Quorum is here. So get back on Licensing Committee, Agenda Item C, Summary of Discussion of Changes in Pharmacy Law included in Assembly Bill 1503 Berman, Chapter 196, Statutes of 2025, including updates on implementation activities. Transitioning to the next agenda item, which is an update on the implementation activities related to AB 1503 that were previously identified and discussed. As a reminder, Governor Newsom signed a board sunset measure on October 1st, 2025. With this action, significant changes to pharmacy law mostly became effective on January 1st, 2026. As I stated during our prior discussion, I'm so proud of the board's effort to pursue so many important patient safety provisions. The board's legislative report and the final outcome on the measure reflect the board's strong commitment to California consumers. I am very proud to be a member of this board and to work with such dedicated consumers and patients and licensees. The meeting materials reflect implementation activities undertaken since the November board meeting. From a process standpoint, I do not plan to review each area separately. I would also like to note that since the licensing committee meeting, the board released special edition newsletter specifically discussing the changes made in AB 1503. In addition, the board posted the statutory changes for 2026 on its website, and the board's webinar describing legal changes for the 2026 should be available by about early February. I will quickly provide my comments on the various items, and then we'll provide each of you with the opportunity to comment. So beginning with the Pharmacy Technician Advisory Committee, as reflected in the meeting materials, member Satinder Sandhu has been appointed to serve as the board member on the advisory committee. Thank you, Dr. Sandhu, for volunteering to serve in this committee. In addition, I have reviewed the draft updates to the board member procedure manual that we will consider as part of the Organizational Development Committee report later in this meeting. I'm hopeful we'll have the application process available in advance of the April board meeting. It is my understanding staff are working with the department on implementation. Members, do you have any comments or questions on the implementation activities related to Pharmacy Technician Advisory Committee, PTAC?
Where would the application be located for the public?
So we're hopeful that it'll be on the board's website with a link similar to how other programs do it.
Will there be like imagine like a press release saying this is now available?
Subscriber alert,
That's right.
I'm
Yeah.
sure, yes.
Thank you.
Okay, seeing no member comments, I am moving on. Then next, implementation activities related to retitling of advanced practice pharmacist to advanced pharmacist practitioner are underway. As noted in the meeting material, section 100 regulation materials were prepared and are undergoing review by DCA. Prior to submission to the Office of Administrative Law, updates to identified applications and instructions have also been made and posted the first of the year. Members, any comments on that? Moving pretty quick, so. All right, next is two provisions updating the definition of pharmacist following the statutory amendment, which clarifies that pharmacists are not restricted to practicing only within the four walls of licensed pharmacy. You may recall that the board voted to initiate a rulemaking to establish parameters for remote processing in the community pharmacy setting. There goes the definition, community pharmacy setting. Since that time, staff have prepared the rulemaking materials. Necessary pre-reviews were completed and the rulemaking file was submitted to the Office of Administrative Law for publication. It is my understanding that 45-day comment period will begin later this month, and the board should be positioned to consider comments during the March 2026 board meeting. I'd like to thank everyone who worked so diligently and timely to expedite the completion and review of this draft regulation proposal. Members, any comments or questions? More to come on that. Next, we have previously taken action on the self-assessment forms earlier as part of the Enforcement and Compounding Committee report, but we'll note that the board is pursuing a Section 100 regulation change. As included in the meeting materials, staff have prepared the materials which are currently undergoing review by DCA prior to filing with the Office of Administrative Law. Transitioning to implementation activities related to the standard of care practice model, you'll note that the board's policy statement has been posted on the board's website and conforming changes made to the board member procedural manual. Board trainings related to HIV PEP and PrEP, as well as naloxone, have been removed as the trainings are no longer required. Further, Section 100 changes have been prepared and are undergoing review by DCA prior to filing with the Office of Administrative Law. Members, any questions or comments on that and standard self-assessment process and standard of care provisions? Okay, then moving to next is pharmacy records provisions. You'll note that the draft FAQs regarding digitizing records are not yet available. I am hopeful staff will have a draft ready for review and consideration for our next committee meeting. Do you have any comments or questions on the implementation activities related to the records? Okay, moving forward is our brief review of the implementation activities related to ownership provisions. As indicated in the meeting materials, the pharmacy license application and instructions have been updated are available on the board website. Do you have any comments or questions on the implementation activities related to pharmacy ownership? Next is implementation activities related to non-resident pharmacies. I want to highlight that many of the relevant provisions do not become effective until July 1st, 2026. As the meeting materials highlight, additional dates for CPJE were added. In addition, outreach to non-resident pharmacies regarding changes has occurred both through the board's subscriber alert system as well as directly via email to facilities that have an email address on file with the board. It is my understanding additional reminder communications will be sent over the coming months as board staff monitors implementation. In addition, you'll note that the board's policy statement related to the role of the PIC was posted. Conforming changes to the board member procedural manual will also be reviewed later in the meeting. Any comments or questions, members, on the non-resident pharmacies? Okay, moving forward here to changes related to the pharmacists in charge and staffing. As noted, the board's policy statement related to the role of the PIC has been posted. In addition, FAQs related to staffing have been updated and posted on the board's website. Any comments, members? Zooming through here, moving to changes related to the pharmacists. So then next is to requirement for chain community pharmacies. Yesterday, we discussed the draft notice recommended by the Communication and Public Education Committee. As such, I will provide updates on the final 4 subject areas. So FAQs have been updated and posted to reflect the clarifying changes made for specially trained pharmacy technicians. In addition, the retired pharmacist license application has been updated to incorporate the new pathway to restore a retired pharmacist license. There are no updates related to implementation of the new fine authority for mail order pharmacies. I also note that staff have developed process to waive fees for a new pharmacy that opens and provides in-person patient care services in medically underserved areas. Members, any comments on those remaining areas that just went over? Moving super fast. Okay, are there we're ready for public comment. So any comment on all those items? I know it's quite a bit, but I feel that we've been talking about this for a long time. So hopefully that if there's any comments can be covered. So any comments? Seeing none, we're ready for public comment in WebEx.
This is the moderator for members of the public on WebEx. If you would like to make a public comment on this item, please click the raised hand icon. Or if you're an audio-only participant, you can raise your hand by pressing *3 on your device. All right, it appears there are no requests for public comment at this time.
Thank you, Sarah. Okay, members, any comments before we move to the next agenda item? All right, we're ready to move on to the agenda item D, summary of discussion and possible action regarding statutory proposal to establish provisions for a retired advanced pharmacist practitioner license and clarify provisions regarding cancellation of an advanced pharmacist practitioner license. Moving to the next agenda item, during the committee meeting, members considered the statutory proposal to establish provisions for a retired advanced pharmacist practitioner license that would also clarify provisions related to cancellation of such a license. As I noted during the committee meeting, given legislative deadlines, should a committee and board agree, I'm hopeful the board will be positioned to sponsor legislation this year. Members, I draw your attention to attachment 2 of the meeting materials that includes the draft proposal. You'll note that the proposal would add new section 4212, which would establish provisions for an advanced pharmacist practitioner to request a retired license under specified conditions, including that the license has not been revoked. The approach offered mirrors a recently implemented retired pharmacist license provisions. In addition, the proposal amends section 4402 to clarify that an advanced pharmacist practitioner license is canceled when the underlying pharmacist license is canceled or not renewed, or when a retired pharmacist license is issued, unless a retired advanced pharmacist practitioner license is also issued. As a committee, we noted agreement with the proposal. Members, I note that there is a motion available, so we could pursue a statutory change on this area. There's not a lot of comments, but I welcome your motion and comments or questions on this topic. Sure.
Okay. I make the motion to sponsor a legislation change to amend Business and Professions Code, Section 4402 and 4400, and add Section 4212, either as presented or consistent with the board discussion.
And as presented is okay, Ricardo? Okay, thank you, Ricardo. Do we have second?
I can second.
Oh, thank you, KK. Awesome. Okay, members, any comments? We are ready for public comment in Sacramento. Seeing none, we're ready for public comment in WebEx.
This is the moderator for members of the public on WebEx. If you would like to make a public comment on this item, please click the raised hand icon. Or if you're an audio only participant, you can raise your hand by pressing *3 on your device. All right, and it appears there are no requests for public comment at this time.
Thank you, Sarah. Okay, members, we're ready for a vote. Renee, how do you vote?
Yes.
Thank you, Renee. Jeanette?
Yes.
Thank you, Jeanette. Jeff?
Yes.
Thank you, Jeff. KK?
Yes.
Thank you, KK. Claudia?
Yes.
Thank you, Claudia. Jay?
Yes.
Thank you, Jay. Ricardo?
Yes.
Thank you, Ricardo. Satinder?
Yes.
Thank you, Satinder. Maria?
Yes.
Thank you, Maria. And I vote yes, the motion passes. Next is summary of discussion of licensing statistics. Wrapping up my report from the licensing committee, included in the meeting materials is a summary of the licensing statistics for the first 6 months of the fiscal year and 3-year fiscal year comparison data. I'd like to highlight that the statistics provided in the meeting materials today, found in attachment 3, have been updated since the committee meeting. As updated, the statistics now include first 6 months data for the fiscal year. Processing times for the various facility business types vary. While a few of the licensing programs are within the board's performance targets, others exceed the 30-day target. As a quick reminder, the processing time noted in the meeting materials represent the oldest application of each type. The average processing time is lower. Thank you all of our licensing staff for working so diligently to process application. I cannot thank you all of you enough on working so hard. In the first 6 months of the fiscal year, the board has issued 5,243 individual licenses and 358 permanent site licenses, with an additional 682 temporary site licenses. As I noted during the committee meeting, I believe these numbers alone demonstrate how busy the board's licensing staff remain. Members, any comments? Questions? Okay, we're ready for public comment in person. Saying none, we're ready for public comment in WebEx. Sarah?
This is the moderator for members of the public on WebEx. If you would like to make a public comment on this item, please click the raised hand icon. Or if you're an audio only participant, you can raise your hand by pressing *3 on your device. All right, and it appears there are no requests for public comment at this time.
Thank you, Sarah. Appreciate it. All right, that concludes my report for the licensing committee report, and we are ready to move to agenda item 13, organizational development committee report. So first several items included in the organizational development committee report are for information only, so I will keep it brief and open up for board and public comment at the end, and will then proceed to the items being presented for our action today. The meeting materials include budget information for the new fiscal year that began on July 1st, 2025. The board's authorized expenditures are anticipated to be about $35.6 million this year. The board's fund condition is expected to decrease slightly at the end of the current fiscal year. According to the report provided by the DCA, the board's fund condition currently has 8.2 months in reserve. As a reminder, under the provisions of Business and Professions Code Section 4400P, the board shall seek to maintain a reserve equal to approximately 1 year's operating expenditures. You'll observe that the budget information included in the meeting materials notes that the staff is working with the department to evaluate the board's fund condition and the cost to deliver various services. Recent budget information reveals that the board will realize increases in several areas of operations. These increases in expenditures, along with the decreases in revenue stemming in part from pharmacy closures, may require the board to consider an increase in some fees. I anticipate additional information will be available at the March 2026 board meeting. Board member attendance and mail vote information is included in attachment 2 and 3, and I'm truly grateful for all our members for their time and commitment to protecting California consumers. Moving to the personnel update, the board currently has 5 vacant staff positions. Recruitments are ongoing. I receive regular updates on recruitments as part of my weekly meetings with the executive officer and monthly as part of our organizational development committee meetings. I know that it's a lot better than what it used to be, so we're very happy with the recruitment efforts. Attachment 4 includes the meeting dates for remainder of 2026. Quick note for members of the licensing committee, you'll note a change in the date for the meeting scheduled for this fall. So just keep that in mind. And members, any comments so far? The areas we covered? Okay, we're moving on. We're ready for public comment on the items that discussed so far. Seeing none, we're ready for public comment in WebEx.
This is the moderator for members of the public on WebEx. If you would like to make a public comment on this item, please click the raised hand icon, or if you're an audio-only participant, you can raise your hand by pressing *3 on your device. All right, it appears there are no requests for public comment at this time.
Thank you, Sarah. Okay, next is moving on to the discussion of proposed technical and non-substantive statutory changes affecting the practice of pharmacy. Each year, the board has the opportunity to submit technical and non-substantive statutory changes for possible inclusion in an omnibus measure. Earlier today, the board approved such changes related to outsourcing facilities that were reviewed and approved by the Enforcement and Compounding Committee. In addition to those changes, staff are recommending several other changes in specified sections of the Business and Professions Code. The proposed changes are included in attachment 5. I have reviewed the proposed changes and agree it is appropriate for the board to seek inclusion of these amendments in an omnibus measure. As I open up for discussion, I welcome your comment and would also entertain a motion if you believe such action is appropriate. I note that the meeting materials and meeting slide include a possible motion. One question for Corinne. If we say authorize staff to work with the legislators to secure statutory changes as presented, and then can we also add any non-substantive technical changes that occur? Can we just try to seek for changes so we don't have to wait for next year that may not have been presented today?
Yeah, I mean, I think might be appropriate to include a delegation to the chair to determine if there are further changes that are not included.
I'm always afraid there could be something that, we should have changed that. So, okay, that would be great if anybody wants to make a motion or any comments.
Okay, I'll do it. I'll try.
Thank you.
And Corinne can help me with the last part. Authorize staff to work with the legislature to secure statutory changes as presented, and authorize the chair to what? Work with staff to something.
Yeah, I mean, I guess you should say delegate to the president to work with staff to determine if further non-substantive changes may be necessary.
As stated by council.
As stated by council.
That works for you.
There we go. All right, do we have second?
I'll second.
Thank you, Claudia. All right, do we have other member comments before? KK, I see you're unmuting. Did you mean to unmute? Nope, okay.
Comments?
All right, we're ready for public comment. Sacramento. Seeing none, we're ready for public comment at WebEx.
This is the moderator for members of the public on WebEx. If you would like to make a public comment on this item, please click the raised hand icon, or if you're an audio-only participant, you can raise your hand by pressing *3 on your device. All right, it appears there are no requests for public comment at this time.
Thank you, Sarah. We're ready for a vote. Renee, how do you vote? Get into that unmute button. Yes.
My mouse was not cooperating. Yes.
Thank you, Renee. Jeanette?
Yes.
Thank you, Jeff.
Yes.
Thank you, KK.
Yes.
Thank you, Claudia.
Yes.
Thank you, Jay.
Yes.
Thank you, Ricardo.
Yes.
Thank you, Satinder.
Yes.
Thank you, Maria.
Yes.
Thank you, and I vote yes. Motion passes. Next is discussion of recommended updates to the board member procedural manual as included in the meeting materials in response to changes in the law and to reflect new policy statements approved by the board. Staff have identified numerous changes to the board member procedural manual. The meeting materials highlight the recommended changes that include updates to the frequency of meetings, addition of information related to the Pharmacy Technician Advisory Committee, as well as updates to the policy statements. As the meeting materials highlight, I agree that the board should also archive outdated policy statements as an appendix. I agree with the changes and also note, consistent with our discussion earlier, that the board's policy statement related to intern experience should be added to the manual. Members, any comments or anything that you would like to add, change? No one's jumping to the microphone. We're so close. We might be done really early. Come on. We need a motion.
I'll make the
Hi,
motion.
President. Oh, I can make the motion.
Thank you. Go ahead, Renee.
Was that to me? Okay. Yeah, I would agree that, thanks for updating this. It's a handy reference. So I'll make a motion. Approved the updated board member procedure manual consistent with the board's discussion, which is as presented.
Perfect. Thank you, Renee. Do we have second?
I'll second.
Thank you. Just so you know, we're also hoping to change the format because it's not been changed since like the 90s I could be wrong. Sorry. I don't know though. Yes.
So I just want to confirm that the motion is as consistent with the board's discussion,
Which is
because
to
that will
archive.
pull in
Yeah.
the intern policy statement from earlier today, because that's not included in the draft.
Also archive the old outdated. Yeah.
Okay, yes, so I'll update that. It was consistent with the board's discussion.
Thank you, Renee. Do we have second? Was it Claudia?
I'll
Okay.
second.
Thank you, Claudia. All right, any other comments, members, before we are ready for public comment in Sacramento? We're ready for public comment in WebEx. Sarah?
This is the moderator for members of the public on WebEx. If you would like to make a public comment on this item, please click the raised hand icon, or if you're an audio-only participant, you can raise your hand by pressing *3 on your device. All right, and it appears there are no requests for public comment at this time.
Thank you, Sarah. We are ready for a vote. Renee, how do you vote?
Yes.
Thank you, Renee. Jeanette?
Yes.
Thank you, Jeanette. Jeff?
Yes.
Thank you, Jeff. KK?
Yes.
Thank you, KK. Claudia?
Yes.
Thank you, Claudia. Jay?
Yes.
Thank you, Jay. Ricardo?
Yes.
Thank you, Ricardo. Satinder?
Yes.
Thank you, Satinder. Maria?
Yes.
Thank you, Maria. And I vote yes. Motion passes. Okay, we are through org development. We're very close to being done. Next agenda item 14, Executive Officer Report. And this time you can talk very slowly. You don't have to run through your report, but anyway, the floor is yours.
Well, I'll keep it succinct. How's that? So thank you for the opportunity. There are several items included for your information. First is the biannual report of the CPJE and NAPLEX, which are included in the meeting materials. The data covers information on the CPJE examinations administered between April 1st and September 30th, and includes a further further background or further breakdown of the data for first-time takers for the California schools that are included in the last 2 pages of the report. Also included in my report is the first of the semi-annual reports stemming from the board's medication error reporting. So summary information is included in my memo, and then the report is included in attachment 2. I do want to just highlight quickly that the mandatory reporting did not begin until September of this year, so we don't have like a full 6 months worth of data for this first report. The data does reveal that there's probably a bit of room for improvement in gaining compliance with both the registration requirements and the reporting of errors. So at the staff level, we intend to continue to focus on compliance through education, continuing those efforts for the near future. Long-term, I would recommend that the board consider either as part of strategic planning or following its strategic planning that a referral of review of these reports occur on at least an annual basis and maybe determine which committee would be the best to review those and then determine the appropriate outcomes. Moving on, in October of last year, the board did receive a petition requesting the board to adopt or amend a regulation to clarify the board's PIC regulation. You may recall the board voted to set the matter for a hearing, which was scheduled for January 6th. On January 5th, the board received a formal withdrawal of that petition. So with that withdrawal, the board did cancel the hearing. Also, in my report, I did provide a brief report on the Joint Forum on Controlled Substances and Medications for Opioid Use Disorder. This forum did occur in December of last year. So continuing collaboration with the other boards, the intent is to leverage the information that was gained through those breakout sessions to identify tangible actions that can be taken to help facilitate better collaboration between healthcare providers. I will provide updates on this as additional items become available. In addition, the last item is the status of various regulation packages. Just a quick note that, at the time that the information is written is a point in time. So some of the regulations have changed in status as we've moved to the next milestones. So as an example, some of the Section 100 packages have been returned to board staff for review and consideration of potential changes. A more detailed report of all of the regulations will be discussed as part of the Legislation and Regulation Committee that is scheduled for April 16th. Thank you.
Thank you, Anne, but you should offer our members for any questions or comments. So any questions or comments for our very dedicated, hardest working EO I know in the entire world?
Yes, I'd wanted to specifically talk about the semi-annual medication error report and to congratulate the staff in providing this information to us. From what I understand, because of the statutory passage of this requirement, we're the first state in the country to require outpatient medication errors to be reported and to be allowed to be collated and assessed. I'm very proud that it looks like 80% of those required have registered, which is just outstanding. It shows that they had developed a great communication process to assist licensees and start and implementing this new process. Specifically wanted to call out Anne and Debbie Demuth, who worked really hard with ISMP to provide this information to us.
Absolutely.
I have a question. So how are they, I know we have the CAMERS system, but how is it actually being inputted, like the data? Who's putting the data in the system for the errors?
So I can tell you from my practical experience. So all pharmacies can utilize what's called API, which I'm sure you know what they are. So that's more fancy process for larger businesses. Satinder may be able to give you a little more information on that. But for smaller pharmacies, they can register as a website and then just submit individual cases to their website. So there's two different kind of ways of doing it.
What are the triggers that like somebody at the pharmacy says this is an error? Like what are the triggers that actually make them report that?
So one, that it should be a real error that happened, meaning that the patient received the medication. So that's laid out in the statute. I may not be quoting it exactly, Corinne, so you can tell us exactly what it says on the thing, but it's when it actually occurs. And then it lays out some of the examples, I would say, because it does say included but not limited to. So anything that a pharmacist in charge or pharmacist determines it to be a reportable error, really, they can report it. Nothing prevents you from over-reporting. So anytime that I find it, so my own judgment, I think this is a reportable event, even though it's a prescribing error, I report it.
Understood. Okay, thank you.
Should it be helpful, the definition of a medication error is in Business and Professions Code 4113.1 subdivision D. I can read it out.
Go ahead and read it.
Yeah, that'd be great.
So it does say, for purposes of this section, medication error includes any variation from a prescription drug order not authorized by the prescriber, including but not limited to errors involving the wrong drug, the wrong dose, the wrong patient, the wrong directions, the wrong preparation, or the wrong route of administration. A medication error does not include any variation that is corrected prior to dispensing to the patient or patient's agent, or any variation allowed by law.
Yeah.
Thank you. That was great. And I do see there's a 0.1 report patient death. After we put this report together, who else sees this report? Are we sending it to the legislators to let them know also what's going on?
No, go ahead, Ann. That or Corinne.
Yeah, so I think that, so big picture, I think that that's why I'm suggesting that like after strategic planning, we kind of figure out like what committee is going to do that. Within the contract, there are, the experts in this area that we are contracting with are identifying those that require, more immediate dissemination. And so they have released information on that. We posted it and sent it out via a subscriber alert. So where we have those events, we are trying to promote those. To make sure that everyone is aware so that they can shore that up right away, while we are also looking at the trending information to potentially develop best practices or those kinds of things. But really, I think some of that will be settled or, further refined as the board determines which committee it's probably going to go to, if that makes sense.
Yeah, that makes sense. Thank you. Because we've only been doing this for 6 months, half a year, just to
It became effective September 1st of 2025.
So there's already.
And for such a short time, I'm very happy still with, yeah.
Yeah, I'm just concerned of the level of medication error. I don't know if that's, is that?
Well, we're
is there a
finally
lot of errors?
peeling the onions. That was, this was a
That's the
mystery
agenda.
data
Yeah,
that,
to see
so
what's going on.
that was the whole point of it, is to have more education and understanding, because it's always been a very inconsistent, inconclusive, or uncertain of what the extent of what the error was happening. And so California became the first state to, require this. And some things, unfortunately, I get the burdens of the administrative burden, but some things it's worthwhile because and again, intention is not to be punitive, it's to learn from it.
Right,
and to
understand.
gain education. Yeah.
Understood. Thank you.
If I could just interject just a point of clarification, since you mentioned the 1% or 0.1% that reported patient death. The report did note that when you read the event narratives of those reports that were categorized as resulting in death, none of them actually described patient death. So that was just a little further context.
And KK, I know your hand is raised, so go to you next.
No, I just want to thank for this report. It is very extensive. One request I do have, which is a follow-up on previous data point that was shared. If we can add trending to the CPJ and NAPLEX passing rates, so we can see if there is any improvement or basically what the trend is with the CPJ and NAPLEX if possible, just to see where the trends are with regards to the new pharmacies entering the practice.
Thank you, KK. We'll work with Ann and McFall on that. Jeanette?
Question for Anne. In the collection of the errors, is it something that you envision where we'll be able to eventually, with the experts that you've contracted with, a dashboard so that we can see the medication errors and perhaps develop a benchmark to improve quality?
Great idea.
Yeah, so I think, because we don't really have our arms around it at all, the kind of the stepping off point was, let's see what even the data is trying to tell us. So I do envision that as we continue to, receive the information and work, I think that as additional data becomes, I think, future contracts, we absolutely could be looking to build those things in. Right now, the contract does not, I believe, have like a live dashboard. But it has like reporting metrics and those kinds of things.
It is my understanding that it may not be available today, but what is been discussed with the contractor is that each individual and when they register in the website, they can see their dashboard of information. And then ideally, at some point, those that have multiple pharmacies across corporations would be able to see some collated. They have other tools that do that. But I think that Debbie or someone in the office has access to high-level information electronically, but it's still in its infancy of developing a dashboard. Is that correct, Anne?
Yes, I believe that that's correct, but I'm happy to confirm and provide a better report at the next one.
Thank you, members. Okay. Anyone else? Claudia?
Another follow-up to KK's question. So for the fail and pass rate, do we know what the biggest challenges are? I mean, why people are failing, or what, if the board can do anything to help increase the pass rate? We can make it brief. just-
Yeah, so I think that if you look at, if you look at the variability among schools, that might, show that, some schools have a higher percentage of pass rate than others. So there is great variability there. I would say we have not taken a deep dive into that kind of data, and I'm not quite sure that we could. But what I would say is pharmacy education varies, and we talked earlier today about how some have accelerated programs. So you're focused on learning it all and meeting all of the requirements in 3 years as opposed to 4 years, right? So have we looked at the data to see if a 3-year program versus a 3.5-year program versus a 4-year program? We have not looked at that kind of data. We would probably have to work with our psychometric firm that it works on this to see what additional pieces of information. But I heard KK talking about, can we start trending some of it? That I think we could do without the psychometricians, and then see what that yields, and then potentially take deeper dives.
And also, if they're an intern, then they're still a student, we can also capture that data, right? Or are they an intern after they graduate?
They're not always students.
So depending on the pathway to licensure as a pharmacist, they may or may not have been an intern, right? So
I see.
if you're already licensed in another state, you don't have to become an intern and earn additional. I'm speaking high level, right? But generally speaking, because there is the different pathways.
Okay.
But generally, if you are a recent graduate, generally, at least if you've gone to school in California, you've been a licensee of the board as an intern.
Understood. Thank you.
Thank you for the questions and comments, members. Are we good? Ready for public comments in Sacramento? We have one.
Sean Kim from California Pharmacy Association. First and foremost, thank you to Executive Officer, Ms. Sutherland, and the staff for all this outcomes and initiatives. I can't imagine how you guys are doing this. This is a lot of work that you're putting into, so we appreciate it. Something to add on to the KEMR ISMP program, as we have collaborated to launch the program amongst two community-based pharmacies. And there were some questions that defines what kind of medication era they are looking for. So it might be helpful to share amongst to the board members to see what questions are included in the report. So not only the officer Corinne has mentioned in terms of what is defined as a medication era, there are specific categories they are looking for, such as like higher dose, low dose, or so that will give a better insights on what the reports is tailored to. And also, there's still the needs of more communication around this program requirements, because there are, as some pharmacies are having inspections, they're learning that, oh, this is a new requirement and we really need to register. It's not for only pharmacists who actually had the med era. So having more understanding around the general public and targeted approach to the ones who haven't registered will be much helpful to achieve full 100% registration if possible. So thank you again for letting me comment, and thank you so much for all the works that you do.
Thank you for the comments, Dr. Kim. Do we have anyone else? Nope, we're ready for public comment in WebEx.
This is the moderator for members of the public on WebEx. If you would like to make a public comment on this item, please click the raised hand icon, or if you're an audio only participant, you can raise your hand by pressing *3 on your device. I have a couple requests. First, I have Monty Goddard, and Monty, you'll be given 2 minutes to speak with a 10-second warning. Please click the unmute me button when the prompt appears on your device.
I was prepared for 3 minutes. My comment relates to the one-day forum mentioned in the executive officer's meeting materials. On behalf of my colleague Pat Irving and all of the pain patient advocates who attended, I want to personally thank President O, Chair Serpa, Executive Officer Stotigan, and all the others responsible for co-hosting the very successful all-day December 17 Prescriptions and Patients Forum. Pat and I were invited presenters highlighting 3 important issues harming Californians afflicted with severe life-altering chronic pain. The issues are the Medical Board of California's 2022 prescribing guidelines, much improved but too little adoption, the state AG's nationwide opioid settlements, disruption of the controlled substance supply chain, and insurance company business practices. I also had the honor of sitting on a panel moderated by Kimberly Kirchmeyer. My 3 co-panelists, one of whom was President O, were all highly credentialed, experienced individuals. All were very supportive of improving the plight of those suffering from undertreated pain. I want to publicly thank Dr. O for his panel comments. As he spoke, I thought, he gets it. In addition to hitting the need of a better vehicle to permit near real-time two-way communication between prescribers and pharmacists, he used real-life examples of the obstacles both the injunctions and thresholds have on patient care. Mentioning pharmacists deal with 200 to 300 prescriptions per day, he employed an excellent narrative describing the life of pain medication prescription. I wish I had time to share more of his content, but I don't. But I do want to share these. This is 3 of his bottom lines. I hope we come to some kind of solution, come to Jesus moment of how we can really help patients who need these medications, because definitely the way our current system is set up is not obviously putting patients first. I think prior authorization has to be
10
figured out.
seconds.
Yeah, this is pathetic. I should have had 3 minutes.
Mr. Goddard, I was told that you are welcome to continue to finish your comment.
Thank you. I appreciate that. The second bottom line from Dr. O, I think prior authorizations have to be figured out. We all want to help patients. We know who they are, and I think nobody wants to just say no, thank you, and move on. We want to help patients. So we need to figure out, we need to help healthcare providers take care of our patients. We need to figure out a way. And last, the challenge and why we are here today is because this is not easy. Thank you, President O. The one-day forum was a great start in addressing the challenge of the current ongoing patient harm. We eagerly await the opportunity to engage in the forum's promised follow-on action items, just as we also do engaging with your upcoming strategic planning effort. Thank you all very much, and I appreciate the extra minute.
Thank you for the comments, Mr. Goddard. I just want to shout out to our executive officer, Ann, and our deputy executive officer, Julie. Many staff were involved in this effort. They really worked hard. Unfortunately, it was a very rainy day in Sacramento. We all got wet. We were up early and we spent all day at the Sac State, spending time and talking with our many other prescriber partners. I thought it went great and we were very happy to be part of it. And I just don't want it to call it a one thing and call it a, one thing and be done with it. I hope that it's a continuation of an effort to work with other prescribing healing arts board and to learn and to provide a better patient care to be able to help patients in need. So hopefully continuing more to come. All righty. Sarah, sorry, go ahead.
This is the moderator. Next, I have Kathy Gomeshi, and Kathy, you'll be given 2 minutes to speak with a 10-second warning. Please click the unmute me button when the prompt appears on your device.
Good morning. Thank you to the Board of Pharmacy and thank you to the Executive Director, Ann Sodergren, for sharing the report. My comment is in regards to the initial sharing of the KMOR results. So I'm a medication safety officer at an academic medical center, and so I'm really pleased to see the board's desire to promote patient safety and in a non-punitive manner and learning from errors and system improvement and things of that nature. I do want to note that in one of the detailed areas, you mentioned the CAMER registration, and it's roughly 80% compliant. I wanted to share that there is still some gray area or some confusion for health system pharmacies that may have an eligible license type, but may not necessarily meet the definition of community pharmacy dispensing. This was shared at previous board discussion when there was discussion of reassessing the language in 4113.1 as well as the FAQs. So for example, clinic administered meds or infusion center pharmacies or investigational drug service pharmacies are potentially licensed with an eligible license type per ISMP frequently asked questions, but interpreting the language of community pharmacy dispensing to an outpatient prescription is sort of still a gray area that we're awaiting further clarification. I know that all of the health system pharmacies in this context that I've spoken with definitely participate in internal error reporting and would appreciate further guidance from the board.
10 seconds.
To meet both the intent as well as the letter of the law. Thank you for the opportunity to comment and looking forward to the public comment period when that opens. Thank you.
Thank you, Dr. Gomeshi.
All right, this is the moderator. Next, I have Scott Takahashi. And Scott, you'll be given 2 minutes to speak and a 10-second warning. Please click the unmute me button when the prompt appears on your device. And this is the moderator. Scott, if you are currently speaking, you're still muted. Let me request to unmute your microphone one more time.
Still muted?
Nope, I can hear you now.
This is Scott Takahashi, speaking as an individual and a licensed pharmacist. I'm sorry I missed a section on the board policy recommendations regarding internship hours. I only caught part of the last discussion regarding the three and a half year programs.
So sorry, Dr. Takahashi. I'm just gonna make sure I have to check with my counsel. So if he's speaking on the previous agenda item, can he speak on it? My understanding is that he cannot, so.
So my comment was actually regarding the last bit of discussion about three-year programs and their ability to produce good
Okay,
candidates.
got it. Go ahead, Dr. Takahashi. Sorry.
And I guess my question was with regards to ACPE's role in accrediting those programs that have been shortened, and how much the Board of Pharmacy needs to invest where ACPE is actually held responsible to that. That's all I had to throw in.
Thank you, Dr. Takahashi.
All right, this is the moderator. Appears there are no further requests for public comment at this time.
Thank you, everyone, members. Any comments based on our public comments?
I was going to ask, can you tell us what, like, the idea of the one-day summit, that and kind of like the main goal of that and some of the action items that came from that?
Yeah, so the joint forum was convened with 5 other healing arts boards, and the intent was to set some foundational knowledge about, the rules of the road, if you will, or like legal requirements and everything else, and to specifically related to controlled substances access, right? So the board, as well as several other boards, we've received public comments about challenges that patients are facing, either receiving access to their pain medications or access to MOUD, those kinds of things, right? And so it was, we can't do this, we can't address this in a silo. We have to reach out to our other healing arts boards, and we need to kind of convene kind of like a summit, right? So that's what this joint forum was all about. And so the joint forum brought together the boards, right? We were there kind of attending, but then we had representatives from the various healing arts boards, the practitioners and consumer advocates and consumer patients, right? And so the whole intent was the first 2/3, I would say, of the forum was educational presentations, right? Everybody needs to approach this from having the same foundational knowledge. These are the legal requirements. These are, the constraints that, practitioners may be facing when they're trying to take care of their patient. But really what it was also intended to do was to facilitate some better dialogue, right? It's not an us versus them kind of thing. It's like, we all need to be in the boat. We all need to be kind of rowing together. So where are there opportunities to address these challenges, and what is within our purview of control to fix? And so the first, like I said, 2/3 was really focused on presentations, fantastic presentations, great panels. And then we had breakout sessions. And actually the breakout sessions were really just intended to allow everybody to like share their thoughts. And so there were specific questions that were targeted, and then the different groups, like we had like a note taker or whatever. And so what we're currently in the process of doing, right, there was a lot of participation, which is fantastic, but then that's a lot of information to synthesize. So that's what we're kind of working on now. It was not intended, in my opinion, and President O spoke about it as well, to be a one and done. This was not check, we've done it, right? This is, we want to make meaningful change, but we need input from others to understand what those meaningful change needs to be. So, we're looking forward to providing additional information as it's available. But there's six entities that we're kind of all working together. So it does take a little bit of time.
Okay. And then my other question was for the other comment, that who's being required to sign up for the medical error or the prescription errors? It was mentioned like the healthcare. There was like I was confused about that. Some people are not
Corinne,
required.
Do you mind speaking on that? Who is required to sign up?
Under the statute, it's community pharmacies, and there's a definition of what a community pharmacy is, which is any pharmacy that dispenses medication to an outpatient, does not include facilities of the Departments of Corrections and Rehabilitation. But I would note that there is also, the board discussed a rulemaking to exempt hospital pharmacies that meet certain requirements from that.
Right.
And back to the joint forum, Maria was there. So thanks for coming, Maria. It was really great that I think the physicians and the prescribers were at least able to kind of get a little bit of what it takes for pharmacies to do what they have to do. And it's never, sometimes we don't really see what the other side have to do. So it was just trying to have an education and understanding of all the struggles that we are all facing. So I think it was really helpful for physicians to see and hear, and prescribers to see and hear, like pharmacies, what we have to deal with and go through that maybe is not as apparent in their busy day-to-day practice. It was great.
That was great. Thank you.
Okay. Well, that is all for the day. We're done, members. The meeting is adjourned. Thanks for your participation. Thanks for members. I guess this is the last time Mr. Mark Johnston will be in this meeting representing CVS Health. So congratulations on your retirement. Your name shall be remembered in this public record forever as your retirement. Congratulations. So thanks, everyone. Thank you, members, for all your participation and your hard work. The meeting is adjourned.